Yes. So we are going to speak first on small is beautiful and how to manage small pupils and cataract surgery. Welcome, Dr. Rohit Om Prakash sir. Please come on the stage. Yeah. So when you have a small pupil, what are the challenges that you face? And what are the difficulties? So it's basically a relative term. How small is small depends on the surgeon's skill, expertise in dealing with these situations. How are the iris tissue properties that would behave, for example, an IFIS versus a routine small pupil, a rigid pupil. And basically the challenges include all the challenges that come with reduced visibility. You could have all the things like iris damage or a small rhexis which can cause a further complication, retained lens material or an improper IOL placement, especially if you are planning a premium lens like a toric multifocal. And if you have a PC rupture, it makes things even more challenging to manage these situations. So all of this can cause a poor visual outcome and an unhappy patient. So how do you fine-tune your surgery? It all begins with the preoperative screening. So when you see the patient on slit lamp and you see a small pupil, immediately it should strike as to what is the plan that you're going to have for this patient. So you ask about medical history, whether the patient has any prostate issues, whether there are any ocular history, whether the patient has been using anti-glaucoma medications like pilocarpine for many years, and just try to gauge what is the pupil size and its maximum dilated position so that you can plan beforehand. What would be the techniques that you're going to use, whether you're going to use a pupillary stretching method or you're going to use pupillary expanders. What would be the phaco settings? Usually you need to use a reduced vacuum and a reduced flow rate, especially in cases of IFIS. And you need to have your armamentarium ready with the right viscoelastics, OVDs, and the pupillary expansion devices. So you need to follow a stepwise approach. Try and see how much the pupil dilates with the mydriatics that you have. And if there are pupillary adhesions, those are the first things that you need to break. Sometimes after breaking these adhesions, the pupil will still dilate, especially if you use high molecular weight viscoelastics. You may not need to use a pupillary expanding device every time. Today you have very good intracameral drugs like Phenocaine Plus, no financial interest, and these can actually help, especially if the pupil comes down during surgery. So if none of this works and the pupil is small for your comfort, then you have to go ahead and use a pupillary expanding device. There is no ego in not using it, and nowadays these are the usual rings and hooks that are available. I would be speaking mainly on the iris hooks, the Malugin ring and the B-hex ring. So even before we start, we need to differentiate between the rigid non-elastic pupil and the elastic pupil. So the elastic pupil is stretchable. So for example, if you just push in viscoelastic, you can see how the pupil expands under it. But you have the rigid ones which will not expand. So you need to differentiate between the two. So in a rigid pupil, you would have on slit lamp a loss of the pupillary ruff and areas of sphincter atrophy. Whereas in the elastic pupil, you will have an intact pupillary ruff and no sphincter atrophy in these cases. The important thing to note here is if you have a case like, for example, an IFIS, you need to avoid pupillary stretching. But because the moment you touch the pupil, the moment you try to manipulate the pupil more, it will cause an increase in the amount of the IFIS, and that can be actually counterproductive. So in such cases, if you have a very small pupil, you can directly go ahead and use a pupillary expander. So let's see, this is a case where you can see a lot of pupillary adhesions there, and it's a very small pupil. So the first and foremost thing is you need to release those adhesions. So I've made 2 side ports, put in stained with trypan blue, and then through the side port I'm gently going in and doing a synecholysis. So this is from one side and then on the other side. But as you can see, even after doing the synecholysis, the pupil has not really opened up so well. So we need a slightly larger pupil for better surgery. So I'm just doing a gentle stretching. So nowadays stretching from limbus to limbus is not really recommended, but here, because I would be planning to use pupillary expander, so I decided to do a very gentle stretching, because without stretching, if you go ahead and then really use a iris hooks too tightly, it can cause irregular tears in the iris sphincter, which can cause an irregular pupil. So now we are putting in iris hooks. So when you're putting in iris hooks, you have to be very gentle. You make the 4 side ports in the area where it's comfortable. So what I do is I first make the 2 side ports for my bimanual, make the main incision because you're comfortable with the main incision and your routine position, and then I adjust the 4 side ports for the iris hooks. So you put in the iris hooks laterally, go in, and sometimes you can push in a little viscoelastic underneath the iris to create that space so that the tip of the iris hook can sometimes be sharp. So I've had a case where I've actually torn the anterior capsule because there was no space. So you need to be gentle, and if you, as you can see, the iris hooks are not really pulled towards the limbus completely. So if you tear it and bring it towards the limbus completely, sometimes it can cause a tear in the sphincter. And now you have an adequately sized opening where you can go in and do a capsular rhexis, and you can see you can go in till whatever visible area is there, sometimes even slightly underneath it. A very gentle hydro dissection and hydro delineation, and then you can move on to your choice of phacoemulsification, whether it's a stop and chop or it's a direct chop, and you need to be in the central safe zone. So in small pupil, you have to remember that it's very easy to catch the pupillary margin. So if you are towards the periphery and if you are on high vacuum and high flow rate, so you can easily catch the pupillary margin, which can keep coming then into your probe. So you need to be very gentle and continue doing your phacoemulsification. And at the end, removal of the iris hooks after the IOL has been put in the capsular bag. Remember, you first fixate it, as you can see, with the McPherson at the limbus, and then remove that plastic plug very gently. Don't pull on it without holding it, otherwise it can actually tear and then pull at the edge. And then you bring it inside, turn it, and then bring it out. So it has to be very gentle, otherwise it can damage the side port incision also. So this was the same patient on the other eye, and as you can see, the synechia are on only one side. So you can use only 2 iris hooks. So the important thing to note is where to use the iris hooks. If they are too anterior, it can cause tenting of the pupil. If it's too posterior, it can cause bunching up of the iris. So you need to be exactly midway. So you can have disadvantages of iris hooks causing sphincter damage like this. So you need to know how much to retract. So this was the case that I said where I had the tearing of the anterior capsule. So you need to be very gentle and use it in a very delicate manner. So this is the Melugan ring, which all of us know. So it has a biplanar structure, so it straddles the pupillary margin. So this was a patient who was a one-eyed patient, trab already done. You can see the trypan blue has gone into the bleb also. And I'm making the side ports and the main incision. So it's a preloaded one, so you just put it into the injector, and then very gently each of the scrolls are then, you can use a Sinskey hook or the Y hook like this. Each of the scrolls are then straddled onto the pupillary margin. So it's very simple and it's quite firm. So in case of rigid pupil, it works the best. And towards the end, you again just hook on the trailing scroll, release the other scrolls, and then you can remove it with the same injector. And then we come on to the BHEX pupillary expander, which has 6 flanges. 3 of them are above, 3 of them are below the iris. There are 3 flanges which have these holes. So we just go in just few minutes more. Yeah. So this is the BHEX ring. So I'm using these 23 gauge micro forceps, which you can use either through the side port or through the main incision. You can push in a little viscoelastic underneath the iris again to make a little space, or you can use a Sinskey hook also. So the first 2 are the easiest, and the last flange is the most difficult. So here I'm using a bimanual technique where I'm using a Sinskey hook to just hold on to the iris, and then you can release the flange with the hole which is held with the microforceps, and you have a nice hexagonal pupil. You can complete the rest of the surgery, and then you disentangle these flanges, hold it with the microforceps and remove it. It's a very gentle ring which doesn't cause any damage to the sphincter, but it can sometimes be a little challenging. So here we have a case of IFIS where many people prefer iris hooks and Melugan ring, but I've used BHEX also. You can see the fluttering of the iris, the iris trying to prolapse. The best thing about any pupillary expander in iris, it keeps the iris, the pupillary edge at bay. So you can use B-hex also. So all you need is to disentangle the flanges and then just hold on to the flange which is closest, and it can come out easily. So this was the patient 6 hours post-op. You can see how the pupil is nice and round. So we have used it in cases with multifocal IOLs also because it's very gentle. So this was a very interesting case. We did a capsulorhexis and a before we even did a hydrodissection, the pupil came down. So remember, the capsulorhexis has already been done and the pupil is now very, very small. Now we went on and used a B-hex. Now, using a B-hex in this condition is challenging, even using iris hooks, because you have a capsulotomy underneath. And you have to be very gentle. Rest of the procedures are the same. There are some struggles. This was a patient with toric. Because the B-hex is a very thin ring, it can easily slip underneath the iris. So when you're trying to put in the first flange, now I'm trying to put in the second one. See how the first one has gone underneath. So you can't retrieve it because you can't go and just put in your Sinskey hook randomly. So you just need to bring it out. Again, use the forceps or the Sinskey and then you can put it. So there are some challenges, but it can be easily overcome. So for want of time, I'll just skip this. Just one modified technique. If you have the flange over the iris just beneath or just close to your probe or the main incision, sometimes it can come in the way. So you can have a slight modification where you can have the flange which is closest to the incision underneath the iris, so it doesn't come in the way of the probe. So this is how you have the flange which is underneath the iris, so the probe, it can go unhindered. So this was just a slight modification. You can use femtolaser also, but for femtolaser, because you make at least a 4.8 millimeter capsulotomy, you need at least 5 millimeter pupil for that. But in this case, we went ahead, did a femto, but we had to extend it. Sometimes femto itself can cause pupillary constriction because of prostaglandin release. If you compare Malugin ring with the B-hex is a uniplanar profile, jointless and definitely more economical. So to conclude, in today's era of increased patients' expectations and more use of premium lenses, optimal use of devices can help us to overcome challenges and make small beautiful. Thank you so much for your kind attention.